Does everyone see the cover slide there? Okay, good. All right, then I'm off on good ground. Okay, so right, as Dr. Bennett said, I just wanted to speak a little bit about the basic principles of the evaluation of decisional capacity, which, as Dr. Bennett said, is a significant issue that we encounter in working with older people. Let's see if I can. There we go. Okay, making sure the slides will advance. So very quickly, just some overall learning objectives today and some things that I'll try to cover. Specifically, the essential legal foundations and principles that guide decisional capacity assessment, the core medical ethical principles that are involved of autonomy versus protection, but also dual roles, least restrictive alternative, and the who's the patient question. Also talk some about the basic areas of decisional capacity. In other words, the basic decisions sometimes that we have to determine whether the person can make or not. And then lastly, the key components that are required for the actual assessment of decisional capacity. I'll say from the outset that I've been doing these evaluations for about 12 years, and I've never seen two that were alike. So I can't emphasize enough the notion of taking each one on a case-by-case basis. And so hopefully that'll take a little bit of pressure off for people who are feeling like they're supposed to find the one true way to do these things. So there we go. So as Dr. Bennett said, this is an expanding concern. I would certainly agree. It's timely, I think, that we're doing this on the Friday before Dr. King's holiday, because decisional capacity and a determination that someone lacks decisional capacity and is therefore assigned to guardian, for example, for healthcare, what we're doing on a fundamental level is depriving this person of their civil rights. And in the past, that in the context of capacity evaluations, this has happened a lot without good practice to support it, without good due process being followed. So the history of decisional capacity evaluations in the decades past is not good. That being said, there are, certainly as a mental health provider, for example, there are circumstances in which I participate in depriving someone of their civil rights. For example, someone who has a florid psychosis and is imminently about to commit suicide. I participate in the involuntary commitment process, which means that I'm removing that person's civil rights to a degree in order to protect them. So there is a mechanism for this. But that process in a mental health context is far better laid out than certainly in the past it has been for decisional capacity determinations. So because the concern is expanding, one nice piece about that is that we've gotten better and better at deciding on some clear best practices to follow. The older population in our country, in our society, and worldwide is certainly growing. There's not even any need to cite statistics about that anymore. But as the older adult population increases, the prevalence of dementias and other major medical concerns that have the capacity to impair decision making grows accordingly. So we're more, for example, more likely to have a stroke as we age. In our society, meaning the United States in general, there is an emphasis on aging in place, maintaining independence, staying home, maintaining our own functional status as much as we can, which is not a bad thing. But what it does do is it opens the door for questions to be asked about our capacities to do so. Likewise, in the US, we tend to value individualism, and you can certainly make the argument that we may overvalue that, that we may be less of an individual than we like to think that we are, but the bottom line is that we value individualism heavily. And again, as a byproduct of that, the notion of having someone help us can cut across the grain. And again, if you're talking about someone who's had a stroke or has Alzheimer's disease, that opens the door for concerns about ability to make decisions. So in going into one of these situations, I mentioned that I've never seen two that are the same. And an important sort of piece of groundwork to lay in approaching one of these evaluations is what's referred to as a consideration of values and individual differences. And this actually includes our own as well as the person in question. A lot of capacity determinations these days are made with a consideration of the context created by the person's value system, their goals in life, their own ethics, their fears, their hopes, their own cultural background, religious background, LGBT status, all of those aspects of human diversity and individual differences that overlap to make us who we are. And so more and more, those have become vital to consider in making these determinations. Related to that, it's important for us to consider how much we truly understand about that person's worldview, especially how it's different from our own. A classic example of that might be in consideration of a person's ability to request physician-assisted suicide. And if I, as an evaluator, have a lot of maybe religious-based moral beliefs against that, I may not be in a position to best evaluate this person's decisional capacity because our perspectives are too different. But especially with older people, we also highlight the operation of the notion of ageism. We all of us are going to hopefully get very old someday and pass away well past 150 years old. We'll have long, vital lives. But that's not tomorrow for most of us. And so we all have our own beliefs and reactions to aging and working with older people. And some of those can be endearing. Some of those can be reactions that push us away. And they're all normal reactions, but it's important to be aware of them because they can affect how we view this person and affect our diagnosis as well as our determination of decisional capacity. So first and foremost, when we move into the question of determining if someone has decisional capacity, we're leaving the medical world and joining it with the legal world. So this is a medical legal issue. It's a forensic issue. In fact, the first one of these I ever did actually was back in the middle 90s, and it was a determination of capacity to stand trial. So that's probably the kind of capacity evaluation most people in general are familiar with because you hear about it in the news. But it also squarely exemplifies that these are medical legal determinations that we're participating in. We participate in the medico side of it in an evaluation of this person from a clinical perspective. But our ability, and this is an important point, our ability to declare someone incapacitated really is limited. We can enter an opinion, but it actually takes a judge to adjudicate that a person lacks capacity, and it takes a judge to assign a guardian or to take other action to, for example, secure finances. What we say is given great weight in most courts of law. So a doctor's opinion weighs a lot more than, for example, a neighbor's opinion of would weigh. But it's important to know that, and maybe take a little pressure off and know that if we're looking at legal questions like should this person have a guardian or not, families may look to us to say, yes, he should have a guardian, get him a guardian. And we can say that, but it really falls to a judge to make that determination. So just to kind of put some objective data behind that, this is the definition and from the codes on incapacitation for the state of Washington. And you'll notice that they mentioned there that a determination of incapacity is a legal, not a medical decision. So I can say, I think Mrs. Jones needs a guardian of person, And the judge may well agree with me, but the judge also has the latitude to disagree with me based on other data. This is a little different than if we're working in the hospital and say Dr. Bennett comes to me and says, I have this person, they're in dire need of a medication change, but they're delirious and they can't really consent to this. I don't think, can we determine if they can? And I evaluate and say, no, I don't think they understand what's happening. They'll take the medicine, but they can't consent to it. We need to get the DPOA involved. Those decisions happen all the time at the clinical level. They happen all the time. But if we're looking at taking significant action, for example, assignment of a guardian, then we've got the court involved. And that's what they're referring to here when they say a determination of incapacity is illegal, not a medical decision. It is based upon a demonstration of management insufficiencies, and I'll show you more about how we assess that here in a second, over time, and in the area of person or estate. So it's very specific. We're concerned about the decisions I make that directly affect me and my world. And then I've highlighted in red here some important caveats. In the state of Washington, age, eccentricity. So the capacity to stand trial eval that I did was on a gentleman with a schizotypal personality disorder who was very eccentric, but stone cold knew what he was going to be doing in court. Poverty, homelessness, or medical diagnosis alone are not sufficient to justify a finding of incapacity. So I got a diagnosis of Alzheimer's disease, but that in and of itself does not mean that I cannot determine who I want to be my DPOA unless I'm evaluated and shown to lack that capacity. I could be homeless, but I have every right to consent to care in the ER. Poverty doesn't have any effect on that. So I mentioned the ethical foundations. This is the big one. This is the one that most people would be familiar with, which is the balance between honoring a person's autonomy and independence while also protecting someone who's vulnerable and cannot protect themselves from harm. This is what we're weighing when, for example, I commit someone to the hospital who has psychosis and is imminently suicidal. We come across this a lot in working with older people, especially. It's really always on our mind. How do we promote this person's autonomy and yet also understand that they may have some functional limits and we need to put meaningful efforts into making sure that they're okay and that they're safe. The epitome of this is assessing decisional capacity, say, for example, to make medical decisions and deciding whether or not this person needs, for example, a guardian of person to make those decisions for them. Because certainly dishonoring someone's autonomy unnecessarily can cause harm, emotional harm, significant emotional harm. On the other side, if we facilitate someone making key medical decisions for themselves who has really no idea what they're doing, that can obviously cause harm. And so more than anything, above all else, our ethical base is the notion of first do no harm. To work for beneficence and well-being and balance these two factors to determine the best avenue. Most of the cases that I have seen have not been clear-cut. Sometimes they are, but I've seen lots of cases where this really took some consideration. And I'll talk a little bit about that under the concept of least restrictive alternative. But these are some of the other ethical pieces which are not uncommon in these circumstances. One of these comes up a lot with older people is who is the patient? For example, if I come in to see Dr. Bennett and I'm 80 and my adult daughter brings me to my appointment and she buttonholes Dr. Bennett in the hallway and says, listen, we think we need to take over Dad's finances. We need you to sign a form that says he can't manage really his money. Can you do that for us and I'll get it after the appointment? That happens every day, probably in geriatric medicine clinics across the country. but it opens up a really key ethical question, which is who is actually the patient here? Is it me? Is it my daughter? Does my daughter have the authority to intervene that way? Does the doctor have my consent to render an opinion about my well-being, etc.? So that opens up some real questions to answer. Related to that, in that same example, Dr. Bennett may have been working with me for 10 years very comfortably as my provider. We have a good rapport. I always trust Dr. Bennett. But now she's been asked to assume the role of evaluator with me. And those roles do not always play well together. As a provider, she's my advocate. As an evaluator, she's not necessarily my advocate. She may be advocating for, in this case, my family and what they want versus me. And so these are often roles that come into real conflict with each other. And then the last one, which is consent versus assent. I have to be able to consent to my medical care. If I cannot, I at least still retain the right of assent to my medical care. This is a big myth out there sometimes with capacity determinations, that if I'm found to lack decisional capacity and I'm given an alternate decision maker for healthcare, that person can force me to have treatment against my will, which is not true. I know it sounds and it should be self-evident to those of us in the medical field, but we've had a couple of situations here where professional guardians thought that they had the right to force someone to tell us to give care against someone's will. So I wish it was more obvious than it is, but I wanted to make sure I pointed that out. So even if I'm found to lack decisional capacity, if I'm refusing to take a medicine, I have the right to refuse to take that medication. So what I call the top 10 core concepts in decisional capacity assessment. We've mentioned that it's an emerging issue. It's really relevant certainly for older adult providers, but also for providers working in a lot of different areas. So for example, working with people who have severe persistent mental illnesses, people who have cognitive impairment as a result of, for example, Down syndrome or other developmental issues, people who have chronic or debilitating illnesses of all sorts. So it crops up a lot. When you start looking for it, you find it. In our state and in most states, a person is presumed to have capacity until proven otherwise. It's a lot like saying you're presumed innocent until proven guilty. And I mentioned earlier the term least restrictive alternative. This is really the watchword in capacity determination. So if I find someone, my opinion is that they don't have decisional capacity to make a decision, I need to think about the least restrictive interventions possible to facilitate meeting their needs in a safe way. And so I use sometimes the phrase artificially restricted. I don't want to artificially restrict this person's autonomy or unnecessarily restrict this person's autonomy, because I know that has mental health sequelae that are problematic all on their own. So we look for the least intrusive thing that we can do. We also look for, related to this, ways to enhance this person's ability to participate in the decision-making process. So for example, even if I'm not going to be the one to make the decision about my medication, say for pain, Dr. Bennett and my daughter might still talk to me about how I feel about being woozy. Do I care if I'm kind of groggy? And I might say, no, I don't like that feeling. And that's important for them to know, to take that opinion as much as I can give one into consideration of my care. In a clinical setting, we generally emphasize using the term capacity versus competency, because competency is a term you'll come across a lot in the court, and it can create a false impression. We may determine that someone doesn't have capacity right now because they're in a state of delirium, but that doesn't mean they've been ruled incompetent by a court. So in some ways, there's a difference there. Competency also, in the bad old days, was viewed as a much broader concept. And, you know, versus now I'll show you here in a minute the various different types of capacities that we consider. Once upon a time, it was taken as much more of an umbrella concept. And if you were found to be incompetent in one area, you were taken to be incompetent in everything. So for those reasons, I try to avoid the term capacity, or excuse me, avoid the term competency in favor of capacity when I'm working in a clinical setting. In general, it varies across jurisdictions, but in general, to say that someone has decisional capacity, you have to be able to demonstrate each of these things in its own right. An awareness of the issues at hand, so an awareness of my medical diagnosis and the surgery that I need and why. I don't have to be able to discuss it like a nurse or a physician would, but I have to be able to demonstrate that I get it. The ability to understand and consider my options and the risks and benefits in this situation. The ability to reason through a choice and communicate that choice that is consistent with my well-being and values. And if I can do that, then you can feel comfortable that I truly am making an informed decision. On the flip side, a finding of incapacity is generally based on the following. I have to have a cognitively disabling condition. So, and that could be a developmental disability that I've had since I was born. That could be a traumatic brain injury. That could be a stroke. That could be Alzheimer's disease. Anything which has the capacity to disable my cognition. And this has to be concretely and properly diagnosed. So, for example, family, my wife coming in and saying, well, he keeps forgetting to pay the bills, concerning, but not adequate to diagnose me with, for example, with a cognitive disorder without appropriate testing and lab work, et cetera, imaging. But beyond this, even if I have a cognitively disabling condition, we also have to demonstrate degraded functional behavior in the specific area of capacity in question. So it's not enough to say he has Alzheimer's disease and see his memory isn't the greatest and he has some aphasia. We've also got to demonstrate that I'm not capable of, for example, managing, making change or a small purchase at a store or writing a check or things like that. This last point, poor prognosis, this is the classic definition, and it's written with an eye towards something like Alzheimer's disease, which we know is not going to get any better. It's only going to get worse. But it moves us into point number 7, which is that actually in the real applied world of all this, incapacitation is not necessarily static, and it's not an all or nothing concept. So I've used the example here today of someone who's delirious, who can't make a decision because they have a very high fever and a terrible infection, and indeed may not have the ability to make that medical decision. But if we cast ahead 3 months and the infection's gone and they're back living at home and their cognition is cleared, capacity quite possibly may have returned. So it's not always a static entity, and it's not all or nothing. So I use the example of handling money, and I have Alzheimer's disease. I indeed may not be able to manage the bills. So I may not need to be keeping track of my mortgage and making sure that check is sent in, for example. But I still may be able to handle, a small purchase with a $10 bill. And so I, as an examiner, might say, certainly, wife needs to probably best take a hands over the major financial issues. But in support of this man's sense of autonomy and dignity, I think it is okay if he has some walking around money so that he can buy himself a Coke if he'd like to. And that's an example of it being not all or nothing. It's also an example of thinking about a least restrictive alternative. So I might be saying, yes, the wife does need to take over the major finances, but let's not go overboard. I think he still can have a little walking around money and be able to have that little good feeling that comes from that. I mentioned that the past history of these is not good, and they have been rightfully criticized for being very vague, very subjective. Um, Letters written on behalf of patients at family request without interviews of the patient, or against the wishes of the patient. Some pretty heavy things that have gone on in decades and years past. Thankfully, we're beyond this now, but we've had to make up for a lot of lost time and a lot of past mistakes. There are two components to decisional capacity that I've alluded to. One is the decisional piece. The other, though, is the executional piece. And you can find someone who struggles based in one or other or both of these areas. So I may not have the ability to remember what's wrong with me or remember what Dr. Bennett told me about a surgery. I may not be able to appreciate that if I don't have the surgery, I could die, for example. I cognitively can't do it. On the other side, I may have potentially the ability to do all that, but I had a gentleman once who had a significant stroke and was so aphasic that even answers like yes or no were not reliable. Couldn't write, and we weren't able to develop any other mechanisms to help him communicate with help with speech therapy. They did the best they could, but he was looking at a very, very complex decision, and there was no way that we could develop a communication method that would allow him to communicate meaningfully about those things. So he quite possibly had the decisional ability to make the call, but he didn't have the ability to execute that decision or communicate it, and so had a guardian assigned. And then lastly, we all face decisions in life, and we have a right to make bad ones. There's a difference between having capacity and using it. In other words, we all on the call have decisional capacity, and I would guarantee there's times when we didn't use it well, in big ways and small ways. I've seen a lot of these, I've gotten a lot of referrals for these exams based on, for example, family doesn't understand why dad is making the decisions he's making, or they disagree with them. And they think that, he must not know what he's doing, when in fact, dad knows a lot about what he's doing. He's just doing something that they disagree with. Along those lines, I've had a lot of referrals for these things from treatment teams. When there's a rupture between the treatment team and the patient and a disagreement, and the treatment team is concerned that the patient doesn't have decisional capacity because he's not following recommendations. And what it turns out to be is that the patient doesn't understand the recommendations based in medical literacy issues, or feels alienated from the treatment team or something along those lines. So sometimes when I get a referral for a capacity assessment, the question I'll ask is, could this be better dealt with by a good team meeting with the patient, by a good family meeting, a family sit down with social work and the patient, for example? Is there just a big miscommunication here? And people are zigging and other people are zagging and thinking someone lacks capacity when they really don't. So I mentioned the different categories of capacity. These are them. The top two that we're most familiar with in working with older people are financial decisions and medical decisions. Within these categories, these can be very complex or more basic. So do I have the capacity to manage my online banking and my online stock? No, probably not. A person may very well not. I don't have that capacity right now. And if I had Alzheimer's disease, probably not. On the other hand, could I make a simple transaction at a store? Quite possibly. Likewise, medical decisions, some are very complex, like to have a surgery. Some are more straightforward, like who do I want to make decisions for me if I can't make them for myself? That's a much more circumscribed question. Other areas, though, that are less commonly known, making a will, which is referred to as testamentary capacity, entering into a contract, which can certainly include like buying a house, buying a car. It also, though, includes marriage. or adoption of a child, those would all be considered legal contracts. Had a case in our CLC here of a person who was encephalopathic due to end-stage liver disease and wanted to remarry an ex-spouse as a last wish in life. And it was actually the chaplain who brought it forward and said, I don't think we can do this because half the time he doesn't seem to understand what he's asking for. And so it literally came down to a question of capacity to enter into a marital contract or not. I mentioned capacity to stand trial. Driving is considered an area of capacity, and driving is a great example of where these things can become very multidisciplinary. So the psychologist may be looking at cognitive functioning, occupational therapy may be looking at things from their angle, the physician may be considering degree of peripheral neuropathy, the optometrist may be thinking about vision. You just never know whose data is going to be necessary to participate in these decisions. Consent to...
Sorry to interrupt.
Yeah.
We're going to have to transition to our case discussion in just a minute. If you have final thoughts.
Yep, this is, I think, my next to the last slide, so thank you. I mentioned consent to sex. That's becoming more and more of a concern as people with cognitive disorders are living longer. And then the last slide, which is just how we evaluate these things, requires an evaluation of cognitive status, neuropsychological testing, labs, imaging, physical exam, the stuff that you know to do. It actually does require all of that. And it requires capacity-specific functional examination. There are specific sets of questions. There are specific structured interviews that can be used to evaluate specifically how I manage financial decision-making, for example, or medical decision-making, those kinds of things. So, and then my final slide is just be on the lookout in these things. It's not unusual to find circumstances where you realize you have an older person who's being taken advantage of somehow, or situations of self-neglect, things along those lines. So it's not unusual to realize you need adult protection services involved as well.